Good day, Ms. Schmalfeldt. I am very pleased to welcome you here to the ESMO News. Initiated by patients today, and Mamma Mia and I say a warm hello indeed.
Yes, a warm welcome from me as well. And it's certainly great that the two of us can discuss not only ovarian cancer, but also the other gynecological tumors, which are just as common. Endometrial cancer is more common than ovarian cancer. Cervical cancer is thankfully rarer, but it more often affects younger women. And I think it's so great that you have included it in your self-help group, that these women also really have a good exchange, that you take care of this. That is so valuable, and for that, a heartfelt thank you, and I am looking forward to now reporting from ESMO, as there were indeed some new developments.
Yes, please report. The endometrial carcinoma is indeed a relatively young carcinoma, so to speak, that is now being newly discussed in many self-help groups, and that makes me happy, because the young women also have very different questions and needs. As we ovaries, I'll put it that way.
Exactly. It is first about a study involving patients who have endometrial cancer, so for whom an endometrial carcinoma has been newly diagnosed, that have a high risk, meaning a stage FIGO3, either due to local spread where it had spread in the pelvis, or due to lymph node involvement that had surgery with tumor removal where the tumor was completely removed. But due to their high risk, they were advised to undergo chemotherapy with carboplatin paclitaxel, and it was now examined whether the checkpoint inhibitor pembrolizumab brings an advantage. We have already seen a study before similar, but there were just patients included who had a high risk or already had a relapse. So that was, again, some more advanced patients who were indeed experiencing a relapse, and now they really looked at in isolation in the initial situation, high risk, whether there is a advantage. Exactly, as we have already mentioned, the patients with newly diagnosed high-risk endometrial cancer who have already undergone surgery and were operated tumor-free. And we know regarding the endometrial carcinoma that we distinguish between various different molecular genetic groups. The typical ones do not have any characteristic. We call it a no specific molecular type. But then there are some that have a mismatch repair deficiency. So the tumor, it cannot properly repair its DNA and is therefore very unstable, which does not mean that it cannot also be aggressive. And then there are patients with a p53 mutation in the tumor. These are really aggressive carcinomas. And then there are also tumors with a polymerase epsilon mutation that are so unstable that they disintegrate on their own and thus have a good prognosis because they practically destroy themselves, these tumors.
High risk means a high risk of relapse, of a recurrence of the disease.
Exactly. And that's also the reason why chemotherapy has been recommended. And the study design was such that it was a large study with over 1,000 patients who were high risk patients for endometrial cancer. They had surgery, meaning they had a removal of the uterus and the ovaries, and also an examination of the lymph nodes in the pelvis and along the main artery. But this could also be done with a sentinel lymph node, that is a sentinel lymph node method. And the group that was supposed to be studied had undergone chemotherapy with carboplatin paclitaxel and pembrolizumab, and the other group had only the chemotherapy. And instead of pembrolizumab, the checkpoint inhibitor, a placebo. And it should be observed if it provides an advantage in disease-free survival and also in overall survival. That was a common endpoint. And now when you first see it, the first curve is disappointing. You see, when you look at all patients, that is regardless of their molecular characteristics in the tumor, as we previously said, no specific molecular profile, mismatch repair deficient, p53 mutated. If you look at them all, then the checkpoint inhibitor, which is the green curve, lies exactly above the brown curve with the placebo. No advantage. We see that after 2 years, 76 and 75% respectively of the patients without recurrence, which is already good for this high-risk cancer. But if we now look into the molecular groups, we see in the group with mismatch repair deficiency, where we know these unstable tumors are very receptive to checkpoint inhibitors and immunotherapies. There we see a clear advantage. The green curve shows 92% without relapse after 2 years. That means only 8% have a relapse after 2 years. And you see the curve remains stable. Up here, this is also what we know with checkpoint inhibitors. while in the other group, it was 80%, only 80% who were relapse-free. So that means for this group, there is an advantage. This study was not designed to look into the individual molecular groups, but with that we see, which we are already doing now when we currently indicate chemotherapy for patients that are mismatch repair deficient, then the checkpoint inhibitor should be added. And we now also have brand new for pembrolizumab. We have a positive EMA vote. We already have for dostarlimab. Another checkpoint inhibitor, and also for durvalumab, we have an approval. So we have many opportunities to administer a checkpoint inhibitor, and we should do that.
And the EMA, could you briefly explain again what that is, since you mentioned it yourself?
This is the European Medicines Agency, which evaluates medications, assesses their benefits, and provides a recommendation whether they are brought to approval. This is Europe-wide, which means it is also relevant for Germany. This still needs to go to the GBA in Germany, which will negotiate the costs again, and that has not happened yet. But with this positive EMA vote, you actually no longer need a cost coverage statement. But the health insurance companies are also obligated to pay for it.
Thank you.
Now we are doing maintenance therapy, which also lasts for over a year, and we need to look at the side effects. And when we look at that, overall, the higher grade side effects were not significantly different. We have 71% in the pembrolizumab group versus 63%, so a bit more serious side effects, particularly grades 3 to 5, where in fact only a single patient actually died during therapy. However, that was not checkpoint associated. It was for a different reason. And we also see hardly any differences in therapy discontinuations and the severe side effects at 10%, 4%. We do see differences, but they are not very significant. One must consider the benefits for the patients. But we simply need to, when one has side effects, take a good look at them to see what kind of side effects they are. If we first look at the side effects caused by chemotherapy, we do not see any difference. Pembrolizumab does not make the side effects worse. This is always the green curve. Hair loss comes from the chemotherapy, as well as anemia, nausea, diarrhea, and the white blood cells. So the side effects are actually all the same. Even the fatigue is not higher with pembrolizumab. These are the side effects we know from chemotherapy, which do not become worse with the checkpoint inhibitor. But the immune-related side effects, particularly the thyroid function, this means that for each cycle, one should check thyroid levels, because hypothyroidism can be very well managed with thyroid hormones. This is a tablet that you take additionally. The important thing is just to recognize it. The skin side effects are different. If a skin reaction occurs, it is really important to contact a doctor immediately, as it can often be effectively treated with a local cortisone cream before it really becomes a severely oozing skin rash, so that it is recognized early. And also pneumonia, such as a cough during checkpoint inhibitor therapy, should not be simply dismissed as just a little cold, but really report it to the doctor, because these are non-bacterial, non-viral pneumonias, which, however, can progress just like pneumonia and can be very serious. And in such cases, it is often necessary to administer cortisone as tablets, meaning systemic administration. And the same applies to severe diarrheal diseases. There is also hormonal gland failure, that is, adrenal insufficiency, where the adrenal cortex fails. This is an extremely serious side effect. Or also, for example, an inflammation of the stomach lining, which also, ultimately, such an immune reaction can occur in any organ that we know. And that's why it's important to prepare the patients well and inform them about it, because these inflammations can all be well managed if they are recognized in time.
Okay, thank you very much.
And with that, I may come to the conclusion. So we have seen, and it is also important, that endometrial cancer can indeed be a very different disease. We have 4 different molecular subgroups, we have different stages, and not every patient is the same. And that is why good counseling is especially important for endometrial cancer, to determine what each patient needs. And it doesn't mean that now every patient has to receive the checkpoint inhibitor, but high risk, and specifically the patients who have this mismatched repair deficiency in the tumor. By the way, this is also an examination that can be very well determined immunohistochemically in fixed tumor tissue. It is not complicated at all, easy to perform, and is standard nowadays for every patient who had surgery or even just a curettage. And these patients, when they receive chemotherapy, should also receive the checkpoint inhibitor. We do not have survival data yet, as the study has not been followed up long enough.
Good, thank you very much. That is very interesting and also incredibly exciting how this is developing now, especially with the immunotherapies, so to speak. Let's move on to cervical carcinoma, to cervical cancer. And initially, this is also about treatments such as radio and chemotherapy.
Exactly, cervical cancer. We have early detection, we have the vaccination, but still there are cancers that really develop deep within the cervix. So higher up, which can simply escape early detection. And not all women are vaccinated yet. Cervical cancer still exists, and it also exists in advanced stages. That means it has grown beyond the cervix onto the lateral supporting ligaments. And there is the bladder nearby, the ureter is nearby, and the intestine is behind it. These are patients who are not easily accessible during surgery because too many important organs would have to be removed during the surgery. And we know that in cervical cancer, it is mostly a squamous cell carcinoma, that radiation therapy works very, very well, and that it is an equivalent treatment to surgery. And it is conducted as radiotherapy in addition to low-dose chemotherapy, therefore radiochemotherapy, meaning a combined radiation and chemotherapy treatment. And now they have also investigated whether it still makes sense to add the checkpoint inhibitor. And there indeed, unlike with ovarian cancer, we really have a rationale. Because we know that in cervical cancer, viruses actually play a role which integrate into the cell DNA, that is the genetic material, and then cause the cell to degenerate. But the immune system has already failed there. It should have fended off these viruses. And therefore, it is a good rationale to say, now to give immunotherapy, which mobilizes the immune system again because it had already failed once. So quite different from ovarian cancer, where we do not have this background. Exactly. All patients who had the initial diagnosis of advanced cervical cancer were included in the study. So that has grown significantly beyond the actual cervix, or has already spread to the lymph nodes, in the pelvis, or also in the area of the main artery. And there were very, very many patients, namely 75%, who also had such lymph node involvement. And again, over 1,000 patients were included, and one group received the standard radiochemotherapy. As we said, radiation therapy is usually given over nearly 5 weeks. And once a week, cisplatin is added to make the radiotherapy work a little better. And the group that received the new concept additionally received pembrolizumab. It is administered every 3 weeks, but it was started with the beginning of the radiochemotherapy. And the patients who received pembrolizumab continued to receive it for over a year. And we had indeed already seen the data on progression-free survival over a year ago with a very good result. And now we have seen the overall survival data at ESMO. The therapy has not been approved so far because the regulatory authorities have said they want to see overall survival first, and progression-free survival is not enough for us. This we have already discussed. And now to the results. These were the data on progression-free survival again. So the data we have already seen, but now with a longer follow-up period of nearly 3 years. And there we see the effect remains. These were the patients who only had radiochemotherapy. These are the patients who additionally received the checkpoint inhibitor. And after 3 years, we have so far seen the data after 2 years. After 3 years, there is still a difference of approximately almost 13% or 12% in recurrence-free survival. Namely 69% in the group with the checkpoint inhibitor and 57% who only had radiochemotherapy. And that is really something we have already discussed before with ovarian cancer. A 12% reduction in patients with recurrences after 3 years is truly a significant success that is worthwhile. And now let's take another look at the data on overall survival, and we see the same thing there. After approximately 3 years, 83% are alive, while it is only 74 to 75% in the group that did not have the checkpoint inhibitor. And that was highly statistically significant. You can see this from the p-value of 0.00. So when there are many zeros, it is always a very significant event. And this certainly leads us to truly incorporate it into our clinical routine with these convincing data. And very recently, the European Regulatory Authority also gave a positive opinion endorsing it. And with that, we now have a good rationale to really offer it to our patients. We also no longer have to submit cost coverage applications, but can actually provide it. Here, we need to look at the side effects again. And there we see the serious side effects. Here, those of greater grade 3 were not so significantly different. When we look here at the treatment-related side effects, it's 69 versus 61%. So there is a difference, but not that we are talking about 20%. Rather, we are talking about an 8% difference. There is indeed also a difference in the very serious side effects. But for that, we simply see better overall survival, and there was no difference in fatal outcomes. And here you can also see the therapy discontinuations. There was in the placebo group 1 patient, and in the pembrolizumab group, there was no patient. And if we look at the side effects again here, these are once again just the side effects, which are caused by the chemotherapy that we know, the anemia, nausea, and also diarrhea. This is indeed not enhanced by radiation therapy. The diarrhea is mainly caused by the radiation therapy and not the checkpoint inhibitor. But if we now look at the immunotherapies, and that was what I had already mentioned before about endometrial cancer, the checkpoint inhibitor is the same substance that we saw in the previous study on endometrial cancer. The thyroid must really be monitored with every pembrolizumab administration, determine thyroid levels. So it's a simple blood test, and then you can immediately see if there's anything unusual. But particularly the diarrhea, the immune-related diarrhea has increased a bit. Thyroid inflammation has also increased. The pneumonia caused by the administration of checkpoint inhibitors is 1% higher. Of course, that's not much, 1 in 100, but it's important to recognize them so that they can be treated quickly. Differences in skin side effects were minor, but this adrenal insufficiency, which we have already discussed, where cortisone can completely fail and needs to be replaced, that needs to be recognized. But you can see it, the patients really say, I am completely exhausted. From one day to the next, this is a side effect that cannot be overlooked, but patients must be informed that it does not come out of the blue, but can be related to the therapy. If you recognize it, you can also treat it well. So ultimately, to summarize, the combination of radiochemotherapy with pembrolizumab in patients, notably with this advanced endometrial cancer, that has significantly grown beyond the cervix or has lymph node involvement. There we should really add pembrolizumab as a new standard treatment now.
That's indeed fantastic, and the numbers reflect it as well. This is really something that excites me completely. Let's move on to the next study. This time we really have a lot. There, radiation is tested in comparison to chemo and radiation. That is also interesting, and we chose it well.
That is actually very nice. We now have an additional option for our patients. These are again patients with advanced cervical cancer, relatively similar. This study did not include any patients with high lymph node involvement near the aorta, but otherwise the disease had also grown beyond the cervix. So here as well, FIGO stage 3 or 4 or lymph node involvement in the pelvis. And here a simpler approach has been taken. Namely, chemotherapy was given before radiochemotherapy. That is the study design. So either the radiochemotherapy alone, as we had it before as well, or an additional chemotherapy was administered before the radiochemotherapy to make the tumor a bit smaller and to start breaking it down a little. And it was a chemotherapy with 6 cycles of carboplatin paclitaxel, but given weekly at a low dosage, so only 6 weeks of chemotherapy, and then, after a week, this radiation chemotherapy had to start immediately, so no longer interval in between, and we have seen that this concept works very well. The patients had fewer recurrences and also better overall survival, more than just radiochemotherapy alone. And now the data on quality of life has been shown, because everything that is additionally given to patients, and if the quality of life is worse, one must also consider whether it overall really has a benefit for the patients. If the therapy works better with fewer recurrences, but the quality of life is poor, and that has indeed been shown once again. First, let's look at the data on overall survival again. One can see through this pre-treatment chemotherapy, we also have better overall survival. In comparison to radiation therapy alone, that is the blue curve down here, with a risk reduction of 40%. And when we look at the side effects, we see through the preoperative chemotherapy, there are naturally more white blood cells that are decreasing. So especially the effects on the blood count are significantly stronger, but are only temporary and have improved again after this chemotherapy. In terms of side effects, it was actually quite manageable. And if we now look at the quality of life, we see very little difference there. we see especially that the women who have received chemotherapy have a better quality of life here at the beginning. Regarding the emotional ability, probably because they were also highly motivated. So simply that something happens quickly. We also see this in clinical practice. It often improves the mood, even though chemotherapy is initially restrictive. The other life data, including physical function, was limited by the chemotherapy. Overall, the entire health was also assessed more unfavorably. And also social functioning, that means how do you have contact with others, was simply restricted under chemotherapy. But you can see here, after 2 years, all patients are the same. So after 2 years, there is no difference here in the quality of life in these individual functions. And if we now also look at symptoms, pain, this was even better reduced at the beginning through the chemotherapy. That is certainly an effect that really should not be underestimated. It is good when one benefits from this initial chemotherapy to better manage the pain effectively. The fatigue was a bit more frequent at the beginning due to the chemotherapy, but was the same again after 2 years. Likewise, nausea and vomiting, and also diarrhea. After 2 years, everything was the same again. What must be said is that the therapy is really well tolerated. Also, the neuropathy, which initially as a result of the chemotherapy, a little increases, everything after 2 years, levels out again. So the side effects are the same in both, and the quality of life was better in all aspects. So we see the symptoms everywhere here as well. After 2 years, we are below 0, and below 0 means better. The therapy has also led to the symptoms being controlled, and the quality of life is better than at the beginning. Now, of course, we have to say, what do we do with it now? Now we practically have 2 options, either the checkpoint inhibitor or chemotherapy before radiotherapy. The patients who were included were relatively similar. In the study with checkpoint inhibitor were more patients who also had lymph node involvement located just above the pelvis, and especially the radiation therapy was really better documented. It was also more modern and sophisticated, as in this study with chemotherapy, which was predominantly conducted in England, that we believe the data from this pembrolizumab study just a little bit, that we simply believe them a little more, and also believe that they are more relevant for our patients. If one can consistently perform radiotherapy at a really high level, nevertheless, we have to say we all live here in an environment where we have good access to medical therapies, that patients receive high-quality radiation therapy, access to checkpoint inhibitors for monitoring. That is not the case in all countries worldwide. One must say, unfortunately, that cervical cancer, the carcinoma of the cervix, are common in Africa, very, very common in India, in many countries, including in Latin America, who do not have access to modern radiation therapy techniques, who do not have access to checkpoint inhibitors. And for these countries, that is certainly a very good option, because carboplatin paclitaxel is available everywhere and can be a very good option. And we also have patients who cannot receive a checkpoint inhibitor because they have a different underlying immune condition, multiple sclerosis or a severe skin disease, that excludes it. And it is also an option for these patients. So we simply have, it's good, we have 2 options. I believe we would, in the clinic, now prioritize the checkpoint inhibitor if there are no contraindications, but also keep in mind the chemotherapy before that.
I thank you so very much. I also thank you for looking at it together with me, which might be interesting for patients, and truly feel from the heart that you are getting better and better at explaining for patients. I just need to reflect that back to you now.
That makes me happy. Yes, it really should definitely get across. There is so much to read on the internet. And then there is also, I have expressed my opinion on this subjectively many times, but I simply want to advise patients well, that they can join the decision-making, what is good for them, and can also see the data. And some patients will also say, if they also see, yes, a little more survival, but that there are too many side effects, that every patient can simply create their own understanding with this data image, what the best option is for them, and above all, that we both want to convey that there are new substances and survival in all patients. Both in ovarian cancer and in uterine cancer, and endometrial cancer has simply become longer and better. And that is indeed simply nice for patients, but for us as therapists just as much, that we can simply develop something further.
Yes, and it is really nice that doctors and patients like you and me, for example, can come together to explain to other new patients what possibilities exist, and this followed up online. That is indeed a great opportunity. Thank you.
I also say thank you very much.
Goodbye.
for the pleasant exchange.